This video we are going to see about oral submucous fibrosis. Oral submucous fibrosis is a chronic, potentially malignant disorder affecting the oral mucosa, and it can involve up to the pharynx and lower part of the esophagus. So it is characterized by deposition of dense collagen within the submucosal layer of the oral mucosa. So basically the tissues in and around the mouth will be more elastic in nature, which helps in swallowing, speaking and masticatory function. But in case of oral submucous fibrosis, the tissues in and around the mouth will be more rigid because of the fibrosis. This condition was first described by Schwartz in the year 1952 as atrophica idiopathic mucosa oris. But later in 1953, Joshi from Bombay redesignated the condition as submucous fibrosis. There has been various definitions that has been proposed for oral submucous fibrosis, but the most widely accepted definition that was given by Pinbock and Sissat in the year 1966, and it goes as oral submucous fibrosis is an insidious chronic disease affecting any part of the oral cavity and sometimes involving the pharynx also. Although it is occasionally preceded and are associated with vesicle formation, it is always associated with juxtaepithelial inflammatory reaction followed by fibroelastic change in the lamina propria with epithelial atrophy leading to stiffness of the oral mucosa and causing trismus and inability to eat. So it basically means that oral submucous fibrosis will have a epithelial inflammation which will be followed by fibroelastic change, that is fibrosis of the lamina propria, and along with that there will be epithelial atrophy that leads to stiffness of the oral mucosa which can cause difficulty in opening the mouth and difficulty in eating. Coming to the epidemiology of oral submucous fibrosis, it is predominantly seen in India and other parts of the southern Asia. So the prevalence rate is about 1.2% in India. So mainly it is reflected by the food, cultural and religious habits that has been followed in India. Coming to the etiopathogenesis of oral submucous fibrosis, it is a multifactorial disease, meaning that it is caused by various factors. So the factors includes areca nut or betel quid chewing, chilies, nutritional deficiencies and certain genetic factors. So among which areca nut is one of the prime etiological agent of oral submucous fibrosis. So the betel quid consists of two basic ingredients. One is tobacco and one is areca nut, either in a raw form or in a manufactured or processed form. So it also consists of slake lime and other special flavonoids that can increase the taste, which is wrapped in a betel leaf as we could see in this picture. So the major areca nut alkaloids are arecolin, arecadin and guacolin and guancin. So these important flavonoids of areca nut are tannins and catechins. So these are very important in the development of oral submucous fibrosis. And other etiological factors that includes chilies is also important in the etiology of oral submucous fibrosis, and nutritional deficiency is also thought to be associated with oral submucous fibrosis. Either this could be precipitated by impaired food intake by the patient due to burning sensation and trismus, or it could be due to iron consumption during cross linking of collagen that also makes the patient prone for iron deficiency. And some authors also believe that it could be a genetic predisposition and there is an association of certain genes. So what exactly happens after chewing of betel quid? So when the patient has a habit of constant chewing of betel quid, it results in chronic irritation to the oral mucosa and that can elicit a chronic inflammatory response. So this chronic inflammatory response results in activation of T cells and macrophages at the site of oral mucosa. So these T cells and macrophages results in production of cytokines, that is namely interleukin 6 and interferon alpha, and certain growth factors, predominantly transforming growth factor beta. So this transforming growth factor beta plays an important role in any kind of fibrosis. It is like a protective response. So these cytokines and growth factor result in transcription of certain genes, namely the procollagen genes and tissue inhibitor of matrix metalloproteinase gene and plasminogen activation inhibitor gene. So all these genes helps in increase in collagen formation and decrease in collagen degradation, thereby resulting in oral submucous fibrosis. So first we'll see the activation of procollagen genes. So these procollagen genes increases collagen production and deposition of collagen into the oral mucosa. But initially these deposited collagen will be in soluble form. That means it can be easily degraded by collagenase enzyme. But as I mentioned, betel quid is not just tobacco and aracanut. It also contains flavonoids, tannins and copper. So all these increases an enzyme called lysyl oxidase, which causes cross-linking of the deposited collagen and make it insoluble to degrade by collagenase. And on the other side, the cytokines increases the tissue inhibitor of matrix metalloproteinase gene and plasminogen activation inhibitor gene. So these two genes causes inhibition of matrix metalloproteinase enzyme, which is nothing but the collagenase enzyme, which is necessary for degradation of collagen, and also decreases the conversion of procollagenases into collagenase. So all these results in decreased collagen degradation. So on the one side, there is an increased collagen production and there is a formation of insoluble collagen. And on the other side, there is a decrease in collagen degradation. All these owing to oral submucous fibrosis. And overall, the pathogenesis of oral submucous fibrosis is concluded as collagen metabolic disorder due to disruption in the collagen metabolism by various etiological factors. And another important thing about aracanut is it undergoes nitrization and it also increases the alkylation of DNA and paves the way for malignant transformation. So, oral submucous fibrosis caused by aracanut is not just a collagen metabolic disorder, it is also a potentially malignant disorder because of this mechanism. Coming to the clinical presentation of oral submucous fibrosis. So, the first and foremost chief complaint in oral submucous fibrosis will be burning sensation on consumption of spicy foods. So, this complaint is mainly due to the atrophy of the superficial epithelium, and sometimes the patient also complains of small vesicles or petechiae, mainly in the initial stages or in the early stage of the disease. But as the disease progresses, the oral mucosa will be more blanched, as we could see in this picture, and it will be more opaque in nature, and on palpation we could able to feel the fibrous band that has been running around. So the fibrotic bands can involve the buccal mucosa, labial mucosa and soft palate and uvula region, and sometimes it can extend up to the facial pillars and pharynx. So the one most common manifestation that we see in oral submucous fibrosis clinically is trismus or inability to open the mouth. So this is mainly because of the fibrosis around the tissues of pterygomandibular raphe resulting in trismus. On further progression, this disease can involve up to the esophagus resulting in difficulty in swallowing. The diagnosis of oral submucous fibrosis is mainly based on the clinical characteristics and also the habit of betel chewing. But the international consensus described a criteria that it should have a palpable fibrous bands and mucosal texture when on palpation, and also the blanching of oral mucosa along with the consistent histopathological feature. So on histopathology, the oral submucous fibrosis will be seen as juxtaepithelial hyalinization, and there will be atrophy of the epithelium as we could see in this picture, and there is a deposition of collagen and hypovascular connective tissue and some chronic inflammatory cells within the lamina propria. So this is the typical histological feature of oral submucous fibrosis, and along with that, if you could see clinically the blanching of oral mucosa and palpable fibrous bands, and along with the history of betel chewing, we can conclude it as oral submucous fibrosis. And in some cases, the histopathological feature will also show epithelial dysplasia, and that is why it is considered as a potentially malignant disorder. And that should alert the clinician that it is transforming into malignancy and we have to take appropriate measures. Another investigation that is used in oral submucous fibrosis includes hematological investigation, serological or immunological investigation, and cytological smear preparation and ultrasonography. So, the ultrasonography is the recent modality. At variable frequencies, it can be used as both diagnostic and therapeutic tool. Coming to the hematological investigation, it is mainly done to rule out iron deficiency anemia, where we could see the paler or blanched mucosa. And serological investigation is mainly to rule out the sclerodoma, where we can see trismus. And cytological smear is mainly done for ruling out any epithelial dysplasia. Coming to the management of oral submucous fibrosis, there are n number of modalities are emerged and still emerging in the management of oral submucous fibrosis. First and foremost, it is an habit related disease. So cessation of the habit will be the most important measure and also as a preventive measure for further progression, and it could be associated with the nutritional deficiencies. So, prescribing the patient with nutritional supplements such as vitamin B capsules, lycopene, and minerals helps in certain improvement. And after nutritional supplements and habit cessation, corticosteroids are the mainstay of treatment and widely used in the management of oral submucous fibrosis. So their role is anti-inflammatory and immunosuppressive property, which is very important in the oral submucous fibrosis. So it should be given either as a topical application or as an intralesional form. It could be combined with hyaluronidase so that it helps in deeper penetration. And other modalities includes physiotherapy, like mouth opening exercises, mouth opening appliances, or ice cream stick method. And newer drugs such as pentoxifylline, interferon gamma injections, perfenadone, placental extracts have also been tried in the management of OSMF. And if the patient is in an advanced stage where there is no mouth opening at all, we have to go for a forceful mouth opening or surgical relieving of fibrous bands. And one of the recent modality includes ultrasonography, which at lower